On the 17th of September this year, it's World Patient Safety Day, and at ESNEFT we've decided to dedicate some time to raising awareness of safe use of opioids. We've had a number of serious incidents in the last few years, and we want to use this opportunity to share learning from them and also raise awareness of how we can safely use opioids in our hospitals.
When a patient is admitted to our hospital with a severe acute pain, opioids can provide effective and much needed pain relief whilst we investigate and treat the underlying medical issue or surgical condition. There are acute pain guidelines available at each site, which you should use to ensure that you prescribe an appropriate dose and route of administration. There are stickers to ensure that this is done in a safe manner. If a patient is experiencing acute pain that is limiting their breathing, it's really important that they are administered either IV or subcutaneous opioids. Only give IV morphine if you feel comfortable and competent to do so. You can use the IV morphine administration algorithm to help you remember how to prescribe and how to administer IV morphine safely. Any nurse can administer subcutaneous opioids, and you can use the algorithm to support you in doing this. You can check age-related doses in the acute pain guidelines at each site, and at Ipswich you can use your lanyard card as a handy reminder.
Age-related opioid doses should always be reduced for patients who weigh less than 50 kilos and for patients who may be oversensitive to the sedative or respiratory depressive effects of opioids. When prescribing, always try to prescribe the opioid in the full form. For example, immediate release oral morphine solution, not just morphine, or immediate release oxycodone solution, not just oxynorm. This helps avoid confusion with the sustained release versions of these drugs. Try and preempt adverse effects that might happen. An easy way to remember how to do this is to use the mnemonic ABC. In this instance, I always think A, antiemetics, so prescribe something for nausea or vomiting should that occur. B, for bowels, patients taking regular doses of opioids will become constipated. And C, for crash team. Naloxone can only be administered in an emergency by nursing staff if it's prescribed. Nursing staff can use the ESNEFT algorithm for administration of naloxone, which is found on the intranet, to remind them how to do this. And there's a helpful sticker to help you prescribe naloxone when you're prescribing opioids that's in use at both sites. When patients come in with a new painful problem and they're already taking long-term opioids, things can get a little bit more complicated. What prescribers will need to do is establish what patients have been prescribed and how they've been taking the opioids. This is really important because not only do we want to continue the pain relief regime that patients are taking long term when they come in with a new pain, but also we'll need to administer extra opioid analgesia on top, and what they've been using in the background will help us to determine how much extra pain relief they'll need.
Sometimes patients don't take their medicines as intended, so it's really important to check what they actually do.
When patients come in on different types of opioids which you haven't encountered before, it can be really useful to use an opioid conversion chart to understand how they compare to morphine, which we're all much more familiar with. For patients who are on opioid substitution therapies like methadone, it's really important to double check exactly what dose they're on with their prescribing pharmacy or their prescribing service like Turning Point or Essex Stars. Methadone is a really complicated and long-acting opioid drug and can be really harmful if prescribed inappropriately, so it's really important to check the dose and make sure you're prescribing it safely. The ESNEFT opioid withdrawal guideline guides you through how to do this.
Medicines reconciliation is really important when a patient is admitted to hospital, so getting those medications right and prescribed accurately is so important, especially when opioids are concerned, because harm can result.
When a patient comes into hospital with any opioids, pregabalin or gabapentin, these must be taken away and independently checked by 2 nurses and then signed into the CD register. Although this is time consuming, it does promote safe custody of CDs and avoids double dosing. We've had an incident where a patient had taken their own medication from their own belongings and been given a dose by the nursing staff, and this has required the patient to have naloxone.
Did you know that at ESNEFT last year we had 36 incidents of where controlled drugs went missing? At ESNEFT, all incidents related to controlled drugs should be reported on Datix, as this helps us to learn from the incidents that have occurred. We have had about 320 incidents related to controlled drugs in the past year. Part of my role as the Controlled Drug Accountable Officer for ESNEFT is to look at these incidents, look at the learning from them, but also report them to what's called the Local Intelligence Network as part of the controlled drug role.
Controlled drugs can be misused and must not be left unattended at any time. This does include anaesthetic rooms, ward clinic rooms and patients' bedsides. We've had a never event where oral morph was administered via IV. When giving oral medication, always draw it up with an enteral syringe. This is to avoid confusion with IM and IV routes. So before administering opioids, check the dosage against pain guidelines. If you've been giving oral and subcut route, please check the dosage against the correct route before administering. Remember, subcut is half the dose of the oral route. Don't ever give a dose to a patient that seems to you unusual or unsafe. If you are unsure, check with a senior colleague, pharmacist or the pain team. This is to avoid causing harm to the patient by giving too large a dose or the wrong route.
Some patients can be really challenging to manage and it feels like we'll never get on top of their pain. Chronic pain is a completely different entity to acute pain and it must be treated differently.
Acute pain is always linked to an underlying condition, something being wrong with tissue or structure. The chronic pain, it becomes less linked to the underlying condition and structure changing and more due to pain processing changes. Pain does not always equal harm. It should be emphasised that medication in chronic pain only plays a small part.
People deal with pain differently. Some people can get caught up in a battle with their pain, either trying to push through things or perhaps starting to avoid things because of the pain. Pain medication is one tiny tool in managing the vast knock-on effects of chronic pain.
Taking high doses of opioids for a long time increases a patient's risk of some serious side effects, including immune suppression, mood disturbance, and of course dependence. More than 120 milligrams of oral morphine equivalents per day is not evidence-based for giving additional benefit for pain, but is associated with a long-term risk of harm due to adverse effects.
The pain clinic has a dedicated opioid reduction pathway to help people who want to look at reducing medication do that in a supported way, understanding more about pain and the effects of their medication.
Some patients who are discharged from ESNEFT will need a short course of opioids to help them recover from their painful condition or surgery. The safest approach for this is to use the smallest dose possible for the shortest possible time. There are some patients who will be higher risk for discharge with opioids. These high risk groups include patients with a history of substance misuse, patients with a history of alcohol abuse, patients who have unstable mental health, or patients who are vulnerable and have nowhere safely to store their opioids. These patients require a careful risk assessment and a detailed plan to ensure their discharge is safe. Please discuss this patient group with the pain team so we can help you make a safe discharge plan. It's important to discuss a de-escalation plan with your patient before they are discharged. This means that the patient will understand that their opioids will be reducing and stopping in the near future. You should discuss the risk of dependency with your patients on discharge. We have a new leaflet, Taking Opioids for Acute Pain, that can support this discussion and be given to your patient. It covers the safe use of opioids, safe storage and safe disposal. For patients who are already on opioids long term, there are lots of resources that you can signpost these patients to. You can also refer them to the Opioid Reduction Clinic. For more information, please speak to your pain team, or you can look at our new opioid awareness page on the hospital intranet.